everybody. Hello, my dear colleagues. Hello from Italy. We are here today for the final day of the OSSTEM meeting online. Let me introduce myself. I'm Leonardo Muzzi. I'm an active member of AC and active member of Italian Academy of Osseointegration. So thank you to all the people that are online with us today. As we know, the pandemic infection of COVID-19 have deeply touched our profession, not only in the daily practice and routine daily activity of dentists, but also from a didactical point of view. For this purpose, thanks to OSSTEM that provide a new formula for didactical activity for dentists. So in this case, the OSSTEM meeting online is the formula that can help us in maintaining our skill and maintaining our didactical activity during this hard period. So thank you to OSSTEM for this great idea. And thank you to all the prestigious professional that helps OSSTEM in this project. As we know, COVID-19 has touched deeply not only dentists, but also a dramatic economic situation was in this period. So OSSTEM, together with Marco Tallarico, promoted a fundraising for help people that in this particular moment have great difficulties. And so some money have been collected, something about 10,000 euros have been collected and donate to Andrea Bocelli Foundation. That is a foundation that give money to people that in this moment need help. So we can have a short movie about this foundation. Thank you.
Good morning, Professor, and welcome to this interview.
Thank you.
Let's start with the first question. How is COVID-19 changing dentistry?
From my point of view, dental clinics have always been safe. Dentists just improve personal protective equipments and protocol to deal with the COVID-19.
Thank you. Let's pass to the second question. You are a professor, right? You hold semesters around the world. What has changed now?
From this point of view, the change was dramatic because most of the meeting have been delayed. Some others has been changed in online event, like today.
Thank you. Is it like education online, smart work?
Yes, the same.
Okay, let's talk why we're here today. You will be doing a surgery as the final part as the OSSTEM Worldwide Meeting 2020. I know we're in streaming live worldwide, over 1,000 viewers. Are you excited?
Yes, I'm so excited. But I think the patient more than me.
I'm sure. Luckily, I'm not the patient.
Neither me.
One last question. OSSTEM Europe and you have promoted a fundraiser to support the Andrea Bocelli's Foundation. Can you explain the reason of this choice?
Yes, the reason is because when I knew that the meeting was delayed, I asked to OSSTEM to take the live surgery and to transmit via streaming. OSSTEM agreed and also promoted a fundraising. So we decided Andrea Bocelli Foundation because it's Italian foundation like me, because of a worldwide visibility and because support kids like you.
Thank you for your time, Professor Tallarico, and good luck.
Thank you.
The world needs our voice now.
So thank you for this interview, Marco. And now, if OSSTEM didn't leave us alone, now we don't must leave alone other people. So I ask you, please donate some of your money. It's very easy. You can go on a social network by OSSTEM and you have to click, and then you can give some money to people that really need in this moment. Is a dramatical economical moment in the entire world. So thank you for your donation. I will remember you, okay? So I would like now to introduce today's speaker that in the next hour will show us how to use technology during surgery. My dear friend Marco Tallarico that today will show us how to manage the patient. A short movie for Marco. So I give the microphone to Marco that will explain us what's going on today. Marco.
Okay. Good morning, everybody. Thank you, Leonardo. He's a colleague, a friend of mine, and today the moderator. I want to thank a lot of people before starting because, as Leonardo told you in the introduction, the OSSTEM World Meeting is moved in online version. I'm very happy and I'm very proud that OSSTEM believe in us in this event. We organized everything in my clinic that today is like a TV set. OSSTEM supported us by phone, by call, supporting us by giving all the materials, but I want to apologize myself if we will have some technical problem, but this is a dental clinic, not a cinema set, so apologize us. But I want to thank the OSSTEM not only for the support, because believe in us, and it will be my pleasure to make all the effort to have a very nice and wonderful day. I want to thank all of my staff, probably the first actor of today. I want to thank all of my friends that supported me, my dental technicians, companies. OSSTEM is the first company that I want to thank. OSSTEM Europe, I want to really thank because supported me every day. I want to thank also the OSSTEM Italy and New Anchorvis is the milling center that produced all the surgical templates and production that we will see in the life surgery. Today I prepared a classical all-on four for implants to support a fixed restoration, but I prepared a case with a very nice digital point of view, introducing the new shape, new design of surgical templates we will see later. Digital technologies help us very well in everyday practice, but we will have time to discuss after my procedure. I want to give a last concept, last but not the least. I really ask to you to donate to the foundation. You already seen the video. Leonardo already speak about this. But please, because it's a very important thing for all of us in this particular situation, I think that is very important for not only the Andrea Bocelli Foundation, but for ourselves. So I think that we can start. I am going to prepare the patient to start with some anesthesia. I will wait you for start the surgery, of course. In the meantime, Leonardo will launch a brief presentation of the case. I met the patient a lot of years ago, but I prepared a story for you in order to explain the case that we will see today. Thank you.
So thank you, Marco. Thank you, Marco, for your competence and for your friendship. So now we have to see and to look at a small video where we can see where we start from, so our patient, what's the beginning, till now when Marco will perform the surgery. Here I am with the maxillary, the part of the patient, okay? And so we have to deal with this maxilla, okay? So let's go with the video of presentation of the case.
Good morning and thank you. Before starting my life surgery, I would like to introduce the patient of today, the topic of this life surgery. But before, I want to really thank all of my staff and OSSTEM Europe because they supported me every day. Let's go to the topic. This is the patient. I met the patient the first time in 2013. This is the situation from a clinical point of view, and this is the situation from a radiographic point of view. I propose to my patient a treatment plan involving teeth extraction and implants, but the patient had very poor economical availability, so they decided to postpone. But I have not seen the patient for 7 years. I met again in 2020, 7 years later, and this is the situation that I found. The patient maintained the teeth in the upper jaw and have just one solitary tooth in the lower jaw. Clinical situation of the maxilla from a buccal and palatal point of view, and in the mandible just one canine. The radiograph shows that the situation is more or less the same that I found 7 years before. So my treatment plan started to project and to realize 2 new completely removable prostheses, starting with a preliminary impression in the maxilla and the same in the mandible. Alginate material is more than enough, so my dental technician can pour the study models, again in the mandible and in the maxilla. With the study model, the dental technician can fabricate the customized impression trays that I will use to take the definitive impression, always for the new temporary prosthesis, but with the definitive materials, but also some bite registration and phonetic registration in order to shorten the total treatment times. So this is the model in the mandible with the customized tray and the phonetic bite at the same time, and the same in the maxilla. So the definitive impression was taken, but before I need to fix and to adapt the customized tray, and also to personalize with light curing resin or thermoplastic materials. And the same in the maxilla. Check, fit and customized. This is a short video about 2 minutes that show a very interesting technique to avoid teeth extraction during impression. As I showed you before with the radiograph, the teeth are very mobile, there are parodontally compromised teeth, so there is a very high risk that the teeth were extracted during the impression. In this technique, I used 3 materials, 2 different kind of materials. This is a polyether for the buccal aspect of the impression. In the palatal part of the impression, I use a polyvinyl siloxane. So in order that 2 different materials cannot adhere between them, so it's possible to remove in 2 times, but I will show with the video. So I use 2 different materials, polyvinyl siloxane in light and medium consistence, and polyether material for the buccal shield of my impression. So after time I can remove vertically the polyvinyl siloxane, and I can remove horizontally the polyether material as is shown on the video. Using this technique, we don't make any kind of force on the teeth. After that, it's possible to put and to adapt the buccal shield of the impression in the base, so that we have a perfect impression. The buccal shield of the impression in the base, so that we have a perfect impression. Of course, we can lose a little bit of accuracy, but this impression will be used to realize the new temporary prosthesis, but make me really, really sure that the teeth still remain in the patient's mouth. It's very, very interesting technique for periodontally compromised patients. So the same in the lower jaw, but we don't need this special technique, so we'll use a conventional material to take the definitive impression and, as I told you before, bite registration at the same time. I also took the facial bow of my patient, phonetic try-in, aesthetics, plane, everything I need to realize the new prosthesis according to aesthetic and functional criteria. This is all of the new data that I collected, so my dental technician can realize 2 new completely removable prostheses. The day of the first surgery, I need to remove the teeth, even if there are very, very mobile teeth. I want to cut the bridge, the metal bridge, and I want to remove 1 tooth each time in order to avoid vertical and horizontal faults. I'm sorry for the video, I speed up the video to recovery time, but you can see after extraction just a bit bone reduction. Today we will need more bone reduction in order to provide space. The first bone reduction was just to avoid any interference on the prosthesis that may create pain of the patients. In this case, but I will use also today, I use PRF in order to speed up the healing. So the first surgery for the patient was teeth extraction, all the teeth of the maxilla and the solitary tooth in the mandible, a bit bone reduction using manual instruments, PRF to speed up the healing, and continuous suture in order to make the healing more quick and safe. And this is the last part of the first surgery of the patient. And the temporary prosthesis the same day of the surgery. So you can show the smile of the patients immediately after the surgery, and I hope the same today. After 7 days, the healings go very well, so I can remove the stitch and I check the occlusion. Because the patient remained without teeth for a long period, we see 6-7 years, I delivered a lingualized occlusion with flat 0 degree, with flat occlusion in the posterior area in order to make the mandible freedom to check the new occlusion. So the patient is free to found new comfortable occlusions. And this has the temporary restoration from a frontal point of view. 4 months later, a few weeks before today, temporary restoration were changed with definitive restoration. Definitive restoration in order to provide a completely removable denture in the maxilla and completely removable denture in the mandible, but that will be supported by 2 implants. I treated my patients in another course in January in Rome in my clinic to place 2 implants in the mandible to support the overdenture. This is a picture of the new prosthesis on the upper jaw and the surgical template in the lower jaw. The new prostheses were fabricated with the same technique that I showed you before, and the day of the second surgery, the patient received 2 implants in the mandible. I always perform guided surgery. You showed a very brief and quick plan with the software, and this is a very quick video of the implants placed in the mandible. The first step is to fit the template then to check the implant position, open a flap. Also today, even if we have a guided approach, I very often open flap in my guided surgery because I want to be sure that everything goes well. In this case, we see some image with microscope. I want to be sure because the thickness of the bone is not so much, so I want to be safe and make safe my patients. The first implant in the left canine position and the second implant in the right canine position. In this case, two OT equators in the mandible to retain the overdenture that was fabricated some weeks before in order to provide an immediate loading the day of the surgery. These are some pictures after healing. This is the maxilla. This is the actual situation. The patient presented with a completely removable denture in the upper jaw and with an overdenture retained by two implants in the mandible. So this is the smile of the patient at today and the clinical situation. This is the maxilla that we need to treat it in the live surgery. So today we will place 4 implants according to the Odon4 protocol, but we need a bone reduction. So for this live surgery, I asked for a specially designed surgical templates, and I really want to thanks the Billing Center, New Anchorbis, because produced and supported me in a very, very impressive way. So in the yellow, you see the base of this specially designed surgical template that could be named multi-pieces surgical template because it's composed by 3 parts. In the yellow, the base that allow me to place the anchor pin and allow me to execute the bone reduction according to the plane. On the left, you can see the implant part of the surgical template that will allow me to place the implant according to the plan, while on the right, in the blue, you can see the index part of the surgical template that allow me to place the surgical template in place at the beginning. Here you can see the production from left to right, the index mounted on the base for the occlusion and stabilize the surgical template and place the anchor pins. In the middle, the base, so I will remove the index. With the base, I can perform the surgical reduction of the bone and also start with some surgical procedure, flap, etc. On the right, you see the implant part of the surgical template that will allow me to place the implants. All of these parts can be changed. The base will remain with the anchor pin blocked in the patient mouth. You can see again the base, the implant part, and the index that are connected at the base. Today, we also performed immediate loading, I hope, depending on the implant stability. With the surgical template, my dental technician received also a prototype models and antagonist with the implants already in position as planned in order to adapt and finalize a prefabricated temporary restoration and metal reinforced temporary restoration. The temporary and the metal reinforcement are prefabricated according to the planning, but my dental technician checked that everything goes well and finalized in a very, very good way the temporary restoration with painting, refining and cleaning very, very well. Okay, so I think that is all. This is a beautiful picture of a maxillary reconstruction. This is printed according to the CBCT scan of the patient. It's very impressive image. With this picture, I think that I have finished my presentation and see you soon.
let's remember we are dentists and we'll remain dentists. So sorry, I would like to apologize. So here now we know exactly what were the therapies of our patient since the time of the actual today surgery that Marco will perform in a few minutes. So let me check if Marco is ready. Marco, are you ready?
Yes, I'm ready. Okay, we are ready. You can see the surgical room. Everything is ready, so we can start. As you saw in the video, the patient is completely edentulous in the maxilla. I already show in my presentation the surgical template that is a multi-pieces surgical template. Again, I want to thank the Milling Center, New Anchorage, because not only produced this template, but supported me every day, every night, including weekend. So, the template is composed by a base, the implant part with the sleeve inside, and the index. The base allows me to place the anchor pins and to guide the bone reduction. But to place the base in the best way, I need to connect the index and ask the patient to close. Chiudi, stretto, aiutalo per favore che c'è la cosa. Chiudi, 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 chiudi. Chiudi stretto come prima, via la lingua. Sta dormendo? Chiudi stretto, perfetto. Presa per ancora più. Ok, the first, no, chiudi, non aprire. Tieni chiuso bene, eh? The first step is to set the anchor pin buccali. Stretto bene, eh? One. Sorry, I will speak in Italian for my patient and English for you. This is the second. I due anchor pin. Me la curarizzi? Anestesia. Apri bene. Puoi togliere quella sotto, eh? Questa no, non credo ci servirà più. We can remove the overdenture in the mandible, so we have more space. And I need to place the anesthesia in the anchor pin position. I didn't take the anesthesia in the palatal before in order to avoid the swelling on the palatal, on the palate that can alterate the position of the template. You can see. Ok, ancora anchor pin. The third and the fourth. As I told in my presentation, I love the anchor pins. I use anchor pins also in the partial edentulous cases. I'm sorry, okay. Okay. Now I need to open a flap. Ragazzi, ricordatemi gli step, dovrebbero saperli tutti. But I want to reinforce the anesthesia on the palatal area. when I perform gated surgery in 85% of my cases, I open a flap. And I really enjoy that most of the OSSTEM users agree with this concept. In this case, the flap is mandatory because I need to reduct the bone. Here, the guide, the base of the surgical template will guide my flap design from here to here. Ditemi se sto davanti. And on the crest. Okay. And here again. At this point, I need to remove the base to raise the flap, and I will put again the base of the template using the Arcon pins as a repositioning keys. And the last. So I can finalize the flap and rise. Ok. Giovanni, riesci a tenermi la pressione più bassa possibile, per favore? Aspira qua. Well, it's very nice. There are some metal part, maybe the sleeve of the anchor pins. It's not a problem, but I'm very happy because surgical template by OSSTEM are without metallic sleeve for the implants, just for the anchor pins, because I use anchor pins that I need to push and not screw. Why? The reason is because I like to remove the template if I need. If I use anchor pins, screwed anchor pins, I can lose stability. With a push, I can't lose stability when I place again my templates. Okay, I take a few time for this operation to raise a flap very carefully. Okay. Okay. La mia testa forse. Turn right. Ok, rimaniamo centrati. Muovi il... Ok. Questo. Okay. Tanto poi devo ridurre l'impo. Ok. Sì. Io.
Ok. Sutura per favore. I just fixed the flap with a 2-3 sticks. Vai, forbici. Questi ne faccio solo 2 giri. No, dico 3. Lascio un po' più lungo. One in the middle and one on the left side. Pinzetta. Chiudi un po' per favore adesso. Ok, guarda. Se Ivano, chi c'è? Leo? Sì, là ci sono i microfoni sopra, li vedi accesi. Sopra il laboratorio, Maurizio. La prima rotella la puoi alzare di un puntino, se vuoi. 1 o 2 puntini. Ok, the last. Che ore siamo, ragazzi? A che ore abbiamo? No, da quanto abbiamo iniziato? Qui 12? Lungo. Deve essere. Sicuri? Eh sì. Vabbè, c'avevamo 15 minuti in più. Ok. Tieni. Dima base. Chiudi un pochino. Ok. Ok. I put again the surgical template. Anchor pins. Open. Apri. L'index. Chiudi stretto. Ah no, la protesi sotto. Okay, just to be sure, because this is most important part, because at this point I will use the surgical template to place the implants. Chiudi, stretto, stretto forte come prima. Tieni stretto, ancora più. Apri, ok. Chiudi, 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 chiudi. Tieni stretto, non aprire, C'hanno la camera al caschetto. Apri. Apri bene. Apri. Ok, just 1 second. Ok. Maybe the flap. Okay, I'm here. morbido il labbro. Chiudi stretto. Apri. I need to check. Mi rimetti la presa di anchor pin? Ok. Ok. Adesso no. Togli un attimo. Okay. I think it's not well perforated, so I put the first and I refine the second. Ok, chiudi, close, close, chiudi, chiudi bene, tieni stretto, non aprire, eh? Mi rimetti la fessa dell'anchor pin. Ok. Apri. Ok. I check also the other. Apri, 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 togli sotto. Tenete montato il piezo. Ok. Ok. Ready for the bone reduction. Vai. Pedale. The surgical template is guiding me. C'è il filo sopra. Ok. The amount of bone reduction that is about 3 millimeters. Here, here. I need to go up to the palatal side, is about 4-5 millimeter thickness. Ok. Hai dolore? No. Here, ok. Specchietto? No, specchietto. And here. Chiudi un po' per favore. Dobbiamo rinforzare un po' l'anestesia. Ok. And the last side. Destra. Morbida la guancia. Okay. Okay. I need to remove once again the template to finalize the bone reduction, and then we can go with the implants. Ok, ancora Piazzo. No. Ok, starting from the first. C'ho questo filo che mi dà fastidio. Ok. I need to connect the first four tagli, cat, non sapevo tagli come si dice. Mi dai un scollatore? No? Okay, here is a little bit angulated because the implant are angulated, so that we should not have the distal part of the implant more deeper, because here we have angulated implants, tilted implants. Ogni tanto mettono la camera al caschetto, ragazzi. Al caschetto ogni tanto la mettono? Vi chiedete perché, Michela? Sì, se non c'è un'inquadratura che non piace o no. Here the bone is more hard. Ah, non so come si può cambiare, dall'app forse sì. Vabbè, se ogni tanto, anche se al contrario riuscite, tanto per far vedere che ce l'abbiamo, fagliela fare ogni tanto. Ok. Ok. Tieni. Devo fare i primi fori prima della riduzione. Scusa? Devo fare i primi fori della riduzione, ma non dovrebbe esserci problemi. Ho fatto io l'anestesia. Dolore adesso? Ok. questa immagine passerà alla storia. Ok, we reduce the bone according to the plan. Questo ci serve a niente. C'è una pallina, qualcosa, giusto una diamantata per rifinire, ma non ce n'è nemmeno troppo bisogno. Piazza una diamantata per rifinire. E la dima base. E i pin. Ok. Dove sta? Ora li trovo. Ok. 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 I just want to refine a little bit the bone reduction, just on the corner, on the angle, but I don't need just here. Mi chiamate un attimo, Alessandro? Ah, no, 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 fa niente. Ok, lima impianti e la prima fresa a questo punto. Ok. Anche l'occhio vuole la sua parte, grazie Giuno. So, I will start with the implant placement, one guy kit. This is the initial drill soft in order to sign the implant placement. One. All the implants are the same diameter length. Two. Three. And 4. After that, the same initial drill, but at the final length, 11.5. Double contact on the bone and on the guide. Che succede? Ok. 1. C'è qualcosa che non mi... C'è il torque basso. Che... No, no, 80 al massimo. 80, 80. Ok, sorry. Stop, stop. Ok. Double contact. And the last. Morbida con la guancia. Ce l'ho 3. Ok, sorry. Okay. I check the double contact and go. Okay. At this point I want to check because in my plan the bone, I noted that the bone is thin. So I want to check so I can remove the base. Here. I can check. Mi vedete sul kit normale mi servono i misuratori di profondità. Il kit normale 1, 2, 2. Ok, intanto l'initial, quella che hai tolto. Ho una sonda, guarda. the first, and the bone. In the bone, a little bit palatal as planned. No, qui non vedo, ma aiuti tu, Giulia. Ok, sorry. Lo vedi tu? Vai. Ok. And here. Ok, and the last. Qui forse col caschetto si può andare. Anche se è storta. Ok, here. All in the bone. The patient has a little bit pain on the palatal. Here. Scusa anestesia, eh? Che cosa? Vabbè, ma tanto vado. Allora, andiamo tutte con le frese, senza espansori. Quindi ridammi la lima base. Sì. Dammi un espansore però. 11,5. Il mount. No, iniziamo da quello grigio. Vai, mount. Scusami. Motore quello degli impianti e poi andiamo al reverse. Ok. In this case I'm not sure I need, but I want to show you that we can combine some kits. This is the expander of the S-set kit. After the first drill, if the bone is thin, I can use to expand a little bit the bone. Reverse, per favore. Cambio. Because after the reduction I have more bone, but the bone is very soft, so I can compact. Reverse. Okay. After here. Okay, maybe the next one. Il giallo. Cambio reverse, normale. I very love to use more than one kit in order to use the reverse, all the benefit of different solutions. So at the end I will place the surgical template for the implants just with the last drill in order to refine the implant site and place the implant. Cambio. Quindi Angela, dopo questo dima base la fresa 4x7. Gli impianti potete già prepararli. Reverse. Aspetta, vai. Cambio. Of course, I can lose a little bit of accuracy, but at the end, I will use the last drill to refine, cambio, and I will place the implant with the surgical template, of course. The last, aiutami qua giù. Oh no, è questo, è questo. I'm sorry. I need to see. Ok, scusami. Adesso. Questo? Cambio? Penso di sì. Yes, the last. Ok, sì, perché c'è il puntino della dima. Cambio? So. La pinzetta, ok. Dammi la dima impianti. Specchietto. Ah, ok, perfetto. Sì, 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 sì. Ah, non c'è interesse. Non c'è interesse. Sta molto angolato lì. Ok. Allora, l'ultima fresa, 4x7. Mettete il programma giusto. 1. Sì, sì, prepari. Ok, this is the last drill, 4 mm diameter, but I will use the 7 and not the 11.5 because I use TS4 implants, so I want to under prepare the last 4.5 millimeters, but I want to be sure that the implants go in the right position. So just for the crestal area. Sorry, this is a bit complicated. Ok. Mount per gli impianti. C'è corto? No, scusami, questo. Ok. Dov'è il primo? Ok. Lavaggio. Dove? No, dopo la togliamo. Attenta. Lento. Non l'aspirare. Ok, this is the flap. Ok. Apri bene, 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 bene. Programma impianti, giusto? Reverse. I go before the reverse in order to be sure that I contact the bone. Cambio. And then I'm go forward. Ok, 35 o... Ok, 35 Newton at the last, a mano. Mi mettete la telecamera del caschetto adesso, è importante, per favore? Ok. At this point is very important. I should place the implant with the yellow line in the slot, but the multi-unit abutment from OSSTEM are not orientated with the vertex on the face of the implants. So I need to orient it in the gray line, not the yellow. So I place the implant a little bit more, and because as you know, OSSTEM have tape A and tape B abutment. The MUA are only tape A. So I need to place not at the yellow, but when the yellow disappear. This is the first, vai col secondo impianto. No. Allora, come l'ho demontato è meglio che chi lo prende lo fa. Ok, reverse. vai, cambia. Double contact. Here the torque seems to be a little bit higher, a mano. Okay. Anterior area, I have no problem because the multi-unit abutment are without engaging, but for default, I set the yellow line. Okay. The third. Sì. No, scusami. I want to be sure, I'm sorry. It's possible to easy remove. Sì. Ok, ancora di ma base. Altri impianti, ok, ok. Impianto. Again, a reverse. Double contact, vai. Mano. Quanto è passato? No, no, quanto è passato, mi interessa. Ok. Preparate i MUA. Via. Ok. Reverse. Vai. Cambio. Ok. I need to... Fammi controllare a mano. Destra. The same, not the yellow. Here, maybe you can see better. The torque is improved. The gray. Okay. So I can remove everything and place the multi-unit abutment. Me la togli e pulisci la dima base, per favore. Ok, questo è il secondo. Gli anteriori. Ok. These are 2 millimeters eye abutment. I don't need the bone mill because I reduce the bone. Secondo. E anche le torrette, Maurizio, mi comincia a dare. Adesso proviamo senza la dima base, se no poi in caso l'appoggio. Proviamo a mettere il provvisorio se ci serve. Sì. Gli angolati. Via. Mi date il control torque? Sì. Sì. Ok. Aspira, fammi vedere l'impianto. Ok. Ok. Aspetta però, dobbiamo allentarla appena, se no non scende. Ok. Togli pure. Timmeli a 10, va, non lo teniamo a 20. Togli pure. Poi tanto si stringono dopo. Ok. Ok. Quello davanti di cacciavite. Quello per gli anteriori. Tutto bene? E tenete pronte le cappette di... No, devo provare prima il provvisorio. Ah, no, le cappette di guarigione, ma devo prima provare il provvisorio. This is a special driver. I can screw on the abutment and screw again. L'ultimo angolato. Devo prenderlo da quel così. Ok. Destra. Aspira. Ah, si vede benissimo, via. Ok. Lascia, perché aveva allentato. Ok. Ok, le torrette. Attenzione. Le cacciavite a mano. Maurizio, stai tremando, eh? Bravo. Così mi piace. Mi aiuti ad aiutare, non sono svidate bene. Ma ti faceva senso il sangue? Mauri? Non ti faceva senso il sangue? Ok. Mi preparate adesso il provvisorio e la dima base. Allora, vediamo se il provvisorio entra. Guardate. È bello largo. First check. Specchietto. Ok, 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 ok. So, dima base. Se no Franco mi strilla se non faccio vedere questo. Anchor pin palatali. Toglilo, toglilo. Toglilo ancora. No, Giulia. Ok. Very nice because I can find the anchor pin position. Terzo. Provvisorio. Mi tira. Ok. La protesi inferiore. Adesso sei pronto con la resina? Chiudi, 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 chiudi. Sì, vai. Teflon? No, quello non ci interessa a noi. Cioè, non va in regia. Ok. Aperto. As you can see, the temporary restoration fit on the base of the template. Chiudi. So I can rebase in centric relation and at the right occlusal vertical dimension. Mi serve acqua. Open. Proviamo a mettere la diga. Garze, Teflon. Mi date il tempo per favore? Tieni, Teflon. 55, ok. La sonda, qualcosa. Compattatore. La metto... Ma l'ha impastata? Prossimo. Dammi... Sì. La metto un po' di lato e poi la metto nel provvisorio. Tieni, te lo pulisci intanto? Maurizio? Vapore. Diga. Aiutami Giulia. Never forgot that we are dentists. I use an endo instrument to compact. Ragazzi, è dato tutto. Ok, adesso questo lo schiaccia giù. Ce l'hai? Tu metti dentro e datemi a me. Mi serve aria per favore, vicino a te Giulio. Non c'è il beccuccio? No, non ci arriverà mai. Prendi il beccuccio e resina a me per favore, con una spadolina. Ah, quindi non la devo mettere vicino alle torrette, non serve? Sì. Voglio un po' di resina vicino alle torrette. Soffia le torrette Giulia appena puoi. Niente, soffia le torrette. Basta. Apri. Chiudi. Stretto. Stretto. Ok. Datemi la sonda. Apri. Giulia, tieni, devi pulire da dentro. Io non vedo. Cerca di liberare le torrette, se no dobbiamo andare con la fresa dopo. Cominciate a montare il manipolo rosso perché a parte l'occlusione ci serve per liberare le torrette se serve, ci mettete una fresa per multilama, tipo quelle per tagliare i denti. Aiutami qua. Aspetta che mi sono alzato. Ok. Devi vedere le torrette, eh? Una volta liberate va bene. Però veloce, giuro, perché sennò poi c'è gli altri. Servono pure quelli dietro. Uno specillo per favore. Ok. Prendi lo specillo, comincia pure a togliere i teflon direttamente. Tanto lo specillo è corto. Apri bene. Ok. Sono più o meno libere? Tutte e quattro? Ok, devono essere tutte e quattro perfette, Giulia. Ok, fammi richiudere. Chiudi. Tieni stretto tu. Ok. Poi se le riesci, probabilmente è meglio l'ortopanoramica dell'endoralia. Giovanni, chiudi stretto, chiudi. Non aprire, stretto. La puoi cominciare a... Sì. Ah, mi sono scordato il mazzo di fiori. Li vende al supermercato? Ah, sì. Io potete chiedere a qualcuno di là, mio cugino, Jessica, chi c'è? Ivano? Puoi chiedere a Jessica una cortesia? Al supermercato qui di fronte, uscendo a sinistra, destra, non so, volevo regalare una pianta, un mazzo di fiori al paziente. Dai, tanto di là stanno a posto con la camera? Batteria, cose, tutto a posto? Avvisa Alessandro che ci pensa lui. Sì, perché calcola che c'hai 20 minuti, 25 minuti. Una piantina, un mazzo di fiori, qualcosa. Grazie. Abbiamo champagne in frigo, però possiamo aprire quello. Tieni chiuso. Ancora morto. Just 1-2 minutes more, but I think that we don't need occlusal retouchment. Apri e chiudi. Apri, gnam gnam gnam. Ok, bite, up, open and close. Chiudi e stop. So we can stay 1 minute more because it's almost perfect. Leonardo, Leonardo, everything okay?
Hi Marco, yeah, it's perfect.
Okay, thank you.
You saw everything, each part of the surgical intervention very well. A very challenging day.
Mi dite che non sento molto bene. Se c'è qualcosa viene di qua. Ok, cacciavite. Open. Ok. 30 seconds more. Specchietto. Via specchietto. Ok, apri bene. Vai con la... Sì. Tenete pronto un cacciavite lungo se non riesco, o quello per viti angolate per favore. O quello per viti angolate OSSTEM. Ok. Ah no, pare che ci riesco. Maurizio, se ci perdiamo le viti ce ne abbiamo 4 nuove pronte. The second. Aperto. Giulia, appena poi togli l'overdenture sotto. Una vite sta qua. Togli. And the fourth. Perfetto. Ok, l'altra vite. 2 stanno dentro. Perfect. Check the stability. Le ultime si muovono un po', bloccale tu. Attento, Tanto... No, ormai non più. Le cappette di guarigione. Maurizio, vieni qua. Prova a bloccarle un attimo dall'alto. In caso me le lasci lente, così ritrovo la posizione. Vedi se riesci a bloccarle? Sì, ok. Sì, però attento che un po' si muovono. Ok. I love the surgical template, but I need to remove. Maybe we don't need more. Ok, questo non dovrebbe più servirci. I put the healing cap just during suture. Then I remove. Now, dental technician refine the temporary restoration. I will suture about 10 minutes and then we will finish. I hope perfect in time. Seems to be, everything seems to be good. Apri bene. Ok, meglio, perfetto. Forse si muoveva la diga, mi sembrava. Sì. Dobbiamo togliere le suture di utilità. Forbicetta. Ok, chiudi poco poco per favore adesso. Adesso puoi stare più rilassata e chiudere. Pinzetta. Una, filo. Prendi filo. Un farabef per favore. Filo. Giulia, Giulia. Ok. Mi date la... No, ok. Qui non serve. Ok. Fate voi. Se lui sta in camera, assolutamente sì. Ok. Ancora anestesia. Mi aiuti un po' con il dolore, per favore, Giovanni, per quello che puoi? Ti rinforzo l'anestesia. È andato tutto benissimo, sta andando, eh? Stasera non devi togliere la protesi, dai. Scusa, 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 scusa. Scusa, è tutta anestesia, perdonami. Attenzione. Sutura. Ok. Prendi l'altro aspiratore. Respira con il naso. No, no, respira con il naso, respira col naso. Ok, il peggio è passato. Manda giù che abbiamo aspirato noi e respira con il naso. Ok. I'm so sorry. Ok. Ci sei, Stefi? Ok. Adesso chiudi anche un pochino, Farabef. Questo... Sì, sutura. Sì, ok, grazie.
Okay, Marco, while you are finishing with the suture, the
sì?
technician will refine the provisional, okay?
Sento male, Leonardo, sorry, I don't hear very well. Speak a little bit close to the microphone.
Do you hear me now?
Yeah?
Okay, while you are finishing with the suture, the technician will refine the provisional, so we show some image of it, okay?
Okay. Yeah. Now I have 10 minutes to suture and the dental technician refine. You can switch the camera. If you have any question, let me know. But I don't hear very well your voice. PRP? Okay. Okay. Just to speed up the healing, I will put PRF between the flap and the implants. No cost, very economical biomaterials, and very biocompatible. Okay, because it adhered to the bone, between the bone and the flap. Attenzione adesso a aspirare, per ragione. Attenzione a aspirare, aspira solo di lato. La pinzetta, per favore. Ok, cominciamo in mezzo. Non fa niente. Tieni. Spengete i telefonini, per favore. Uscite coi cellulari da qui, per favore. Ma lo so che voi non ce l'avete, non so se è Giovanni, Maurizio, non so. Forbici. O forse sono di là perché noi sentiamo il microfono, ragazzi, scusate. Dai, devo rimetterlo, aiutami. Pinzette? È Giulia che si nasconde tutto. Sì. Okay. I see that the flap are good repositioned although the bone reduction. So I will place normal suture in order to push the flap a little bit apical, but we have the multi-unit abutment. Multi-unit abutment, the benefit of the multi-unit abutment is to improve the soft tissue, is to create a smooth titanium surface in the soft tissue area, in the transition zone. So I will push the flap with this continuous suture, simple suture, and maybe I will cut a little bit the flap on the apical area, on the releasing incisions.
Okay, thank you, Marco.
But you can comment, you are a surgeon more expert than me.
No.
Leonardo, you can see that multi-unit abutment are very nice in this situation because the implant are at the bone level.
I love it.
A little bit above, you see. The palatal area is 0.2, 0.3 millimeter, a little above. But intentionally, I didn't place the implant deeper because we have 3-4 millimeter of soft tissue zone. The multi-unit abutment can compensate.
I completely agree with you. I love this kind of abutment.
Può darsi sia di là. Vabbè, ma tanto lo sentiamo solo nel ritorno noi. Destra. Sì, ok. Preparate un altro filo, comunque servirà. Oh. Sempre uguale. Angela, tu rimani qua per favore. Sento più tranquillo. Tocca un po', controlla un po' questi. Ok? No? Non la toccare. Ora sì. Ok? Grazie. La miseria, non cambiati 3 di cavetti. Lo so, ma... vabbè, non sarebbe una diretta, sarebbe una registrazione. D'accordo? Maurizio, tutto ok? 5 minuti, eh? Mica sta a casa tua qui, eh? Ci tagliano... Maurizio, non ho mai suturato così piano in vita mia. Quanto tempo dall'inizio? Maurizio, 4 minuti. Non mi interessa, mettici un flow, qualcosa, ragazzi. C'è il flow rosa. C'hai un flow rosa nel cassetto. Cambio filo. Dopo. Poi se serve qualcosa mettiamo dopo. Dopo cambiamo filo, Angela. Forbice. Tieni. No, no. Cambia a fare aperti qua. Tieni Giulia. Quello è quello che vedono loro adesso, sì. Toccala il meno possibile, state questa. Casomai allarga un po' la scena così si vede meglio. Maurizio, 3 minuti, eh? Quello potremmo anche non farlo, ragazze, perché siamo un po' lunghi, eh? Poi lo facciamo dopo, lo fa dopo Giulia. Stefano e Ionosi. Dopo la lasta, dopo la foto, succede. Ragazzi, mi dovete dire quando è 10 e 13 minuti, quando mancano 2 minuti e 15. Possiamo andare pure lunghi, però vorrei evitarlo. Al massimo 1 minuto. 12, ok, no, noi a 15 dobbiamo finire. 2 minuti, Maurizio. Fai prima di me, dai. Fai prima di me. Leonardo, we have 3 minutes. If my time clock is perfect. 1 to 2 minutes for the shooter. I screw the temporary and finish.
Did you use resorbable suture?
Yes, it is.
Okay.
Yes, because maybe I will not unscrew the prosthesis for some weeks, so I prefer resorbable suture in order to avoid unscrew the prosthesis is not needed.
Okay.
Maurizio, 1 minuto. Ok. Perché mo per trovare spazi delle torrette qui ci vuole, qui dobbiamo spingerlo giù. Allora, tira bene. Dobbiamo posizionare quello un po' più apicale. Sì, sì, sì. No, no, vabbè, se andiamo lunghi 1 minuto. Stefania, anche se non mi segui più di tanto. Ah no, con la telecamera, tanto in caso mettono quella al caschetto. Ok? Stavi muovendo la luce, scusa, mi ho sbagliato io. Pensavo che muovevi la camera. Dico, tanto se anche non si vede benissimo, metteranno la... lo so. Grazie. Oh, oh, oh. Ok. No, è stato troppo veloce. Troppo veloce, Maurizio. Tu hai corso. No, no, va bene così. No, no. Giulia, io mi fermo qua. Là, ci vedo. Lama nuova, possibilmente. Pinzette. Giulia, c'hai tu? Sì. Devi tirare bene, non vedo io. No, qua io sto. Giulia. Ah. PRF. Ok, un'altra sutura, un altro punto. No, no, quello di prima. The last suture. Provvisorio pronto, cacciaviti pronti, tanto l'avvitiamo e basta. Giulia, lastra. E se Alessandro riesce a fare una foto. No, vabbè, la foto non serve. Alessandro? Ok. Sì, sì, no, dico giusto le lastre perché le foto farai una immagine della telecamera alla fine, adesso. Questa parte di adesso. Perfetto, così lo metti tu dopo. Maurizio? Vabbè, dai, metti, dammi. Puntata. Che c'è il fiatone, Maurizio? Non vedo. Forbice. Ok. Cacciavite. Now we are ready for the temporary. Everything should be good. And I'm ready for the Q&A. Apri. No, butta dentro. Ok. Sutura e pinzette. Ci sono già le viti dentro, Maurizio? Me ne mettete almeno una frontale? Pinzette? Ok. Seconda. I'm sorry. Cosa, Maria? Cacciavite, cacciavite. Sorry. And the last. Overdenture sotto. Puoi toglierla. Apri. I'm sorry, scusa. Via la lingua. Ok, scavalca. Andata. Chiudi. Ok. Ci siamo. Mi dai il tuo apribocca per favore? Sì, quelli delle foto. Apri e chiudi. Ok, just a smile of the patient and I will came to you, Leonardo. Just 10 seconds. But everything seems to be okay. Carta d'articolazione?
Okay, perfect. We wait for you.
Yes. Just I want to show you a 24th smile. Apri. L'altra per bocca. Maybe this one. Tenete qua, Stefi. Ok. Chiudi. Chiudi bene. Apri. Chiudi. Stretto. Stretto forte. Apri. Pinzette. Chiudi. Stretto forte. Apri. Chiudi. Ok. Davanti ci sta. Perfect. I'm finished. And I will come for the Q&A immediately. Thanks, Leonardo.
So, congratulations to Marco, a very challenging surgery. So, we would like to hear from his voice what were the problems, what are the characteristics of this surgical intervention. Very congratulations, very.
Thank you very much. I again want to thank a lot all of my friends, but first of all of my staff, because without my staff, everything is not possible. I think the audience can trust that it's alive because maybe I have a lot of signs, my face for the microphone, for the camera, etc. So I'm really happy because we plan complex cases to management in 1 hour 15. Maybe we take 1 minute, 2 minutes more, but the audience can apologize us for a lot of things. So I think also for 2 minutes more. I'm very happy because my fear before the intervention was the accuracy of the temporary restoration. This was perfect. So I calculated to spend a little bit more time during this procedure.
But on the contrary, I spend a little bit more time in the anchor pin fix section, but as I explain in the presentation, maybe this is, I don't know the first, but one of the first multi-pieces templates. People that perform guided surgery really know that bone reduction, edentulous patients, immediate loading are some of the most complex cases to management with the guided surgery. The fourth is the post-extractive. So, but bone reduction in particular is not too easy to management. So I spend a little bit more time to set the base of the template, but as the audience knew, is very important because with the base I had managed the bone reduction, the implants, and last but not the least, the temporary restoration in order to be sure of the vertical dimension that is most important in the fully edentulous patient.
So I would like to ask you something about changing, a way of changing over from analogic to digital dentistry. If one dentist will want to do this step, what advice you can do to them? It's easy to pass from analogic to digital dentistry.
Thanks for your question. I can tell my history. I very like digital technology. My clinic is full of digital technologies, but I still think that could be innovation addition. So digital technology can help us, but we need always to take in consideration the tradition, so the analog protocols. Then I think that there are two ways because a doctor can shorten the learning curve with the digital technologies. The first is maybe the age. I don't want to speak about old or young, but is obviously that the young generation are more have more practice with the digital technology. So I think that for the younger dentist, the passage between the analog to digital will be more easier. The second, I think, is the patient. If you have a patient for the digital technology for this work, I think that the learning curve can be shortened. But in my story, I can tell to the audience that a few years ago, there was a lot of problem with the digital technology that in the last year disappear. Every year, the digital technologies improve in with less complication, less problem, and improve in accuracy. So I just want to ask a very pleasure from my point of view. You have to trust in the digital technology, because if you try one time and if you try not in the right way, the risk is that people don't like digital technology that used. You have to use and you have to perform a learning curve because it's most important. Last but not the least, I teach that team approach is very important. But with the digital technologies, there are one more member of the team, the CAD designer. So the people that is between the dentist and the dental lab. So the team approach is already most important.
So if it's easy for young dentists, I'll probably exclude it from this step just to hold. Okay, a question on the case of today. You have planned a bone reduction. Why did you do this? What was the reason you performed this bone reduction that we saw in the surgery today?
Okay, thanks again, because as a dentist, before surgeon, I don't like to remove the bone. We put a lot of effort to increase the bone, so it's not easy, but psychological is for the doctor to remove the bone. But in this case, like in most of the cases, the bone is thin in the crestal part, but also we need some spaces to have more chance to reduce complication for the prosthesis. So as you
saw in the video, I reduced a little bit the bone during teeth extraction. Maybe coming back, I will perform a little bit more reduction at the time of the extraction, and probably we don't need today. But the reason is to improve the thickness of the bone and to create the prosthesis more resistance with the right spaces, also facilitate the hygiene maintenance for the patient.
So definitely to mask the line of transition between prosthesis and tissues in this case too. Okay.
Also from aesthetic reason, but this depend by the plan.
Okay, we all see the perfect accuracy of the provisional restoration. Really is not so common during this kind of surgery. So you deliver the same prosthesis you have planned in the initial phase. It was completely the same.
Okay. First of all, I publish a lot of manuscript and take a lot of measurement to demonstrate the accuracy. And even if I publish very good accuracy, each intervention at the end is a surprise that everything goes well, because each procedure maybe could be different from others. My initial plan, coming back to the case of today, was delivery a fixed removable solution, so a titanium bar grooved on the implants and a removable overdenture. This because the patient needs a little of support for the lip, and removable solution can allow the patient to maintain the iron and to reduce the complication, because between the overdenture and the denture and the bar, there is the attachment that can create resilience on the system. So looking at today, I think that also a fixed solution could be right from an aesthetic point of view, because the implants are positioned in the right way, but from the hygiene maintenance and to reduce the complications, I prefer to maintain the original plan, to switch from the fixed temporary restoration to fixed removable solution. From a functional and aesthetic point of view are the same. It's not removable denture, it's implant supported. So I maintain the original plan at the end.
Thank you. So we look in your surgery a multi-piece guide. It's not so common. So can you explain us what are the advantages of a multi-piece guide in these cases?
Okay, the benefit of the multi-pieces guide is to have a lot of tools in the same plan, because we use in the past we have one template like the index, one template to place the anchor pins, one template for the implants, and not template for the bone reduction, or another template for the bone reduction. So this could create some problems during the management. In this case, with the same templates, we reduced the number of times that you need to remove. As you showed, we need to remove sometimes, but with the anchor pin is very fantastic, because we can find the final position. So the multi-pieces template is an tools that can help the clinician to maintain, in case a little bit less complex, to maintain the base, just to change index and the implant part of the surgical template to place the implant, but can open the future to a lot of idea. So it's open for idea from everything.
So many surgeons ask this question. The sleeves you use in these guides are plastic sleeve, but usually we see in movies and surgery metallic sleeves. Do you consider an advantage to have plastic sleeves instead of metallic one?
Okay, at the beginning 2 years ago, when I used the template without metallic sleeve that OSSTEM placed in the market, I think in the European market a couple of years ago, was strange for me, because for a lot of years I used metallic sleeves. So the first time seems that the plastic was not so so strong, so accurate. But as I told you before, I don't stop. I continue, I take a lot of measurement, and I publish two very interesting manuscripts, and the final accuracy of the template without metallic sleeve is higher than the template with metallic sleeve. And probably the reason is in just one word, because the plastic is customized. With the metal, we can have some sleeve that touch the teeth, that touch the bone, we need to refine, etc. With the plastic, everything can be customized in the plan and milling procedure, not at the chair. So, and then it's very interesting because during the live you see a little bit metal part from the sleeve of the anchor pins. Just to be honest, OSSTEM, for the OSSTEM, they have the pin that are screwed, so without metallic sleeve. In my practice, I use the anchor pins that have to be pushed since 15 years. But the reason because I still use this kind of anchor pins is because, as I showed, I need to remove and place the template a lot of time during my surgery. It's a complex case. In the daily practice, also just to check if everything is okay. So I like anchor pins that I can remove and push without loose stability.
So, thank you. Now a question for me, personal. I'm an analogic dentist, so my surgery is analogical and only a little part digital. So I'm making the famous step now. And I would like to ask you, the same case, managed with analogical process. What do you think? Will be easier? Will be more difficult? What do you think about?
Okay, just to be honest, I think that from a surgical point of view, with a freehand approach, the surgery maybe would be 15-20 minutes less, more quickly, because you don't need the template, etc. The flap the same, but you go directly to prepare the implants. But I think that to place the temporary restoration, to place the bone reduction according to the plan, to place the implant in the prosthetically driven position is not so accurate freehand. So maybe you would spend a lot of time to set the temporary. You need to take an impression and send to the dental lab and make a miracle to set the temporary.
Another question. I saw you using the asset kit for bone compaction. Okay, I love this procedure. Do you always use in the upper arch this kind of procedure?
Okay, in general, most of my cases I just under prepare. But for example, for the live, my message is that I love to use more than one kit because we can need several tools. But I want to take this example because I use the under prepare with halfway preparation, and I obtain it 35 Newton at the last millimeters. With a full arch, more than 25 is enough for me, not single. But even I use under preparation, halfway preparation, the stability is very, very perfect. Without this, maybe it was not possible to place the temporary for not stability.
So, definitely you consider the digital technology a great advantage for a dentist, actually. Do you think the future will be only there?
Okay, not easy to respond. Okay, I think that the digital technologies can help the dentist. At today, I want to be honest, people know me. From a diagnostic point of view, for the diagnosis, for the planning, I think that 100% fully digital technologies. For the delivery of the immediate temporary restoration, for the delivery of the definitive restoration, still today mixing analog and digital technologies could be the best because dentists need a learning curve. So to obtain the results that I obtained today is due to a very nice team approach and learning curve. So it's possible, everything I do, I'm not a Superman, but the learning curve is important. And I repeat, if you perform a case tomorrow and spend 1 hour more for the temporary, don't worry, the next will be for 5 minutes, the next again will be 30 minutes, and then you can put everything for 15 minutes.
Okay, we are waiting for the highlights of today. I ask you if they are ready.
Okay. Wow, we are on the highlights. We are on the mouth of the patient, yeah. Ah, okay. But I think you can remove our and let just the picture. Okay. So this is okay. This is the template with the base and the index. It's most important in the fully edentulous patient to stabilize with the lower arch in this case, because we are not teeth like in the partial cases. So like this picture, it's very important that everything is okay at this point before fixing the anchor pins. Anchor pins, the first are on the palatal aspect, the buccal aspect, then you can remove the lower jaw, the lower prosthesis, you can remove the index and set the other anchor pins on the palatal. Okay, as you show in the video here, I have a little bit problem because the one anchor pin, the drill doesn't go up to the end, so I need to refine, but I check again with the index, so I was very, very sure. But as I told you before, this is one of the first multi-pieces template, so please apologize, but I checked when I put again the drill for the anchor pins, I checked again with the index to be sure. Also maybe because the flap can create some problems. The flap, as I told you during my live surgery, I always 80-85% of my cases I open flap. Even if most of the company in Europe advertising guided surgery, flapless surgery, mid body, you can do everything, I completely agree, but to proceed with a flapless approach, you need different characteristics. You need a lot of bone, you need keratinized tissue. So in most of the complex cases, you don't have a lot of bone, you don't have a lot of keratinized tissue, so the flap is to be open. And sometimes, even if I think that everything is okay, I open a flap just to be checked. Because, for example, tonight I will go to my house, I play with my kids, and I sleep very well because everything goes well, and I check that everything went well. Go. The flap is always open. I put again the template. I already told you here I have to check again with the index that the template is in the right position. Okay. So the question before, maybe free hands, I already placed maybe you at now still again to place the temporary, and I finish. So I can more. After that, the bone reduction. I don't like to see the picture again because I love the bone. I told you before, some time is needed. According to the original All-on-4 protocol, bone reduction is important for aesthetic reasons, for functional reasons, but also to make the patient condition to maintain the hygiene, etc. Even if maybe I will finish with the overdenture, I reduce to reduct a little bit in the bone because the thickness was very thin in the part of the bone was very flat. What? Okay. The bone was very flat. I refined with the piezo, and I'm ready to place the implants. At this point is a very normal guided surgery. I just prefer to use the expander. Coming back, this is the first drill. We have the soft, the initial, and then the drill for the planned length. So we have 11.5 millimeters before the initial and then the final length to have the double contact. I remove also because I want to check, as I told you before, and use the expander. I tested the expander through the templates. Maybe it's possible, but it's not according to the protocol. So I prefer remove and check. So to expand the bone, I use the 3.5 millimeter expander in order to reduce the bone drilling in all the sides. In the anterior, the bone was a little bit dense, but in the posterior was very poor. After expander, I put again the template. I use the final drill at 7 millimeter because I wanted to make the implant side very perfect according to the plan, because maybe with the expander I could move a little bit. So I rectificate the implant site, but 7 millimeter in order to maintain under preparation in the last 4.5 millimeter. Then the implant placement. You can go, Alessandro. Okay. As I told you before, it's very important. I want to repeat this concept. The yellow line is oriented on the face of the internal hexagon of the components. So type A according to the catalog. Abutment type A. The multi-unit abutment are the vertex oriented on the yellow line. So the face is 60 degree moved because it's type B. So the most important is that we don't have to put at the yellow line and move 60 degree. Or the 60 degree means between two yellow lines. It's very, very important because otherwise we spend a lot of time with the temporary, and we told guided surgery doesn't work. No, it's the multi-unit abutment is not in the correct position. Maybe this is a suggestion for the OSSTEM to produce multi-unit abutment tape A and B to use free hands of in the guided surgery. All the implants positioned, the multi-unit abutment, very easy. Free hands approach, you spend a lot of time to place the multi-unit abutment. Here we have bone reduction, the crest is flat, and already pre-planned, so it's very easy to place the multi-unit abutments. Minutes, dental technician just refine because I need to rebase temporary mount. It's not possible to have the temporary finish because guided surgery is accurate but not 100%. So I want to rebase in the patient mount. We just base in 5 minutes to rebase, refine. Then my dental technician is refining the temporary restoration and suture just with the attention to maintain the flap more apical. This is the picture during the rebase. For implants, I use the rubber dam because we are dentists. So and it's not a surprise, but it's very, I'm very proud of my staff that everything goes well. And with the guided surgery, very, very often we have these results. With the free-hand approach is not so automatic. This is some picture from the dental lab. I use PRF in this case. I don't know if it's important, but it's free. I have 10 minutes to spend, and it's free. So there are most studies, one also from a friend of mine, Dr. Gatti, that stated that with the PRF, a patient can feel less pain during healing. So why not? Okay, some picture of the temporary. Again, the suture. And the temporary restoration in place. So I will leave the temporary for 8 weeks at least, if I have not problems. This is the picture. My eyes is not so good, but seems to be perfect in line, implant is perfect position. Wow. So if there are no problem, I prefer to leave the temporary for 8 weeks in order to leave those integration without any problems. So if it's some retouch from aesthetic point of view, phonetic, I will ask to the patient to wait. So if I need, I can remove, but otherwise I will remove for refine, rebase, and functionalization after 8 weeks.
Okay, thank you, Marco. Very, 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 very nice, very important. I invite all the colleagues to listen to the advices that Marco gave us. That very important that the digital technology is not the only way. We have to have the basics of surgery, and then we can approach and shift to digital technology that can definitely help us. If we see the X-ray or this morning intervention is very, very important to see. Okay, now that someone tell me there's a surprise, so stay with us. Don't leave. Only few minutes. So yeah, so Marco, thank you very much. Thank you very much for your hospitality and your wonderful structure. Thank you for your competent surgery.
Stay here because we have 1 minute for the final greetings and ceremony. Okay, stay with us.
So now we are waiting for this big surprise. I don't know what is going on. So please stay with us for a few minutes again. I'm looking for Marco that is close to me. Where is Marco? So I hope you enjoy this online meeting. Very challenging case, a very didactical case. As you can see, there are some difficulties. There have been some difficulties during the intervention, but really perfect at the end. Really perfect at the end. Sorry for the technical problem. Oh, wow. The big surprise of today is our patient that finally have her teeth. So I think I look like very perfect. It seems. So, how do you do? Come sta, signora? Very well, very well. So we are happy that everything is finished well. So thank you to our gentle patient that is today. So this is for you. Okay, it's a bench of flower.
Okay, everything okay?
Commossa.
Yeah, she's touched by the bench of flowers. So thank you very much for your attention. See you as soon as possible for a new online OSSTEM meeting. Wait for you in Italy. Bye-bye. See you.
Propose a fundraising for the Andrea Bocelli Foundation because this foundation is from Italy, like me, is with wide visibility, like the OSSTEM, and support the kids like you.
Thank you. Thank you for your time, Professor Tallarico, and good luck. The world needs our voice now.